All right, thanks, Dr. Black. So, like you said, I'm going to talk about some antibiotic prophylaxis, some of the guidelines that we have compared within Canada, AUA, and the EAU, and talk about some of the benefits, the risks of giving antibiotics or overprescribing antibiotics, and then Dirk's going to give us a presentation a bit about some of his antimicrobial coatings that are pretty exciting coming down the pipeline. I don't have any disclosures. So antibiotics, this guy kind of gets the prize, or he's known in the media for being the guy who discovered antibiotics, Alexander Fleming. In 1927, he discovered penicillin by accident. He went on a month-long trip to the lake and left his Staphylococcus cultures open on his lab bench, and they got contaminated with a fungus, and penicillium grew, and there was an area of inhibition on his agar plates, and he was able to eventually purify penicillin from this fungus, and it became widespread and revolutionized medical practice. But this guy, he kind of beat him to the punch, but doesn't get the credit. Paul Ehrlich, he's a physician scientist. He was interested in immunology, hematology, and antimicrobial chemotherapy at the time. He came up with this idea of a magic bullet, that there was substances that you could utilize to target certain bacteria or certain life forms, and he actually used aniline dyes. He passed away in 1915 of a cardiac event. I was kind of hoping he would be, bladder cancer given the aniline dye use, but no luck. He actually developed the first cure for syphilis, so it's the first antibiotic targeted towards a small bacteria, and it was mainly used until it was replaced by none other than penicillin in the 1940s. So it was an arsenic-containing compound. You can see down below there. It was pretty tough to use and pretty tough to take, but it was effective treatment. So with the magic bullet theory that Ehrlich had, he didn't know that this is kind of what we were going to be up against in the days to come. This is the Lower Mainland antibiogram for 2019. Showing the resistance patterns of several uropathogens as isolated over the course of the year in 2018. So you can see that there are some drug resistance bacteria out there, and every patient's a little bit different, and these are something that are becoming more common to see resistance patterns, and something that you can take a look at on your local antibiogram for most likely uropathogens and what the most effective treatments would be.
We can find that.
This was just on Life Labs. You can just Google antibiogram, BC antibiogram 2019, and you can look back all the way to 2014 or so. Yeah. So like I said, we're going to talk about the current guidelines, some of the risks and benefits, and then some novel approaches to antibiotic prophylaxis. So the guidelines, the CUA's most recent updates from February 2015, AUA in June of just this year, and EAU in March of 2017, so fairly recent. Most of the antibiotic prophylaxis guidelines state that you should be giving these prophylaxis within an hour before starting a procedure, and they should not extend beyond 24 hours postoperatively for most circumstances. So I think every urologist has their favorite antibiotic. This was a study by Lawson and his friends in 2013 in a center in Calgary. They looked at all patients who received a TERP within a year and formulated what antibiotics they got. So you can see a very large discrepancy between what patients had. And so the question was, do we need a guideline? You can see that there is no rhyme or reason for a lot of these choices in antibiotics. So the guidelines for transurethral resection of the prostate, all three big guidelines recommend antibiotic prophylaxis for this. They significantly reduce the number of febrile UTIs, bacteremia, and fever. There was no difference seen in the choice of antibiotics used. And I'll show you a slide with some of that data. Perry and Barrett in 2002 did a meta-analysis of 32 randomized controlled trials, and they showed that there was an overall 77% reduction in sepsis. So if you're not using antibiotics for a TERP, you should. I think everyone is. But here's just a summary of some of the studies that they looked at from the CUA guidelines. Anywhere from ceftriaxone, Septra, Macrobid for 10 days after catheter removal, a wide variety of cocktails here, and the data said that there was no difference between any of them.
There was no antibiotic.
There is, yeah, cephalexin down here with a 90, whoops, here, with 90 days, but you're right, I did notice that was one that was noticeably absent, but lots of ceftriaxone, so interesting how we use NCEF here. Right. For routine cystoscopy, all three guidelines oppose the use in routine cystoscopy. A study in 2014 of 3,100 patient cystoscopies did not use antibiotics and compared rates of febrile UTIs. 22% of the patients were found to have asymptomatic bacteria at the time of cystoscopy, and only 1.9% developed a febrile UTI. It was more common in patients who were colonized pre-cystoscopy, but all patients responded to oral antibiotics within 24 hours, and there was no admissions for urosepsis, indicating that routine cystoids should not be using antibiotic prophylaxis. For trus biopsy, it's one of the dirtier procedures that we do. All three guidelines recommend antibiotic prophylaxis. The CUA recommends that we use 1 day of antibiotic prophylaxis versus a 3-day treatment course, which I think is different than what we're doing in Vancouver. They don't necessarily specify a type of antibiotic to be used, but rather you should look at the patient's recent antibiotic use as well as previous resistance that they've had from urine cultures. The AUA also recommends against a 3-day course of antibiotics, and the EAU, same as above, but say that rectal prep with povidone iodine reduces the risk of infections. Yeah. The which, sorry?
So one of the trials there for a study that the swap and after the Yep. Wow.
Okay.
They're different studies, but we did a study where we actually cleansed the rectum. That's our radiologist would do that.
Okay.
I think our 3 days is clearly against the guideline.
Yeah.
It seems to work.
Yeah.
So we're hesitant to change it because we don't have a big problem. But clearly it's not.
Yeah. Okay. So, I mean, this was in the guideline. I didn't go and search out the rectal prep, but yeah, it was something that was different about the EAU guidelines. So maybe they had different studies in there.
Different ways of doing an iodine enema, for example, might be more effective. For us, the radiologist would wipe it with the swab.
Okay. For routine shockwave, extracorporeal shockwave lithotripsy, the CUA and AUA say there's no role for antibiotic use in low-risk patients. They say that symptomatic UTIs and bacteria will be increased in patients with known struvite stones. Sometimes it's impossible to know if you're treating a stone whether it's going to be struvite until after the fact, but if it is a previously known stone former with culture-positive stones, then consider antibiotic prophylaxis. And the EAU recommends antibiotic prophylaxis for all patients with catheters, nephrostomy tubes, or known infected stones, which is different from the North American guidelines. This was just the forest plot here, of the data that was used in the CUA guideline, showing that there was really no significance to antibiotic prophylaxis for SWAL.
If you're just thinking about your cystoscopy, if those rules come from the U.S., where cystoscopy is usually done with sterile prep and drapes and eventually gown and work, which is what they did when I was with it's quite different than how we do. I imagine the nervous infection would be much higher. It's pseudo-sterile.
Right.
And the broad recommendation against antibiotics, I wonder if that applies.
Yeah. And of course, if you're doing a trial, you're probably more likely to be paying attention to sterility and things. Yeah, I agree.
sometimes hard to expose. So, collapsing on you as you're trying to do it.
For non-shockwave stone manipulation, all three guidelines recommend antibiotic prophylaxis, and again, tailoring based on epidemiology and previous cultures, but no more than 24 hours of postoperative antibiotics for prophylaxis. The CUA considers for all patients based on your previous susceptibilities or local epidemiology. The EAU based on severity of stone burden, anatomic position, and patients with related risk factors. So patients with distal ureteric stones, they said if it's going to be a simple procedure, or you anticipate a simple, quick procedure, may not necessarily need antibiotic prophylaxis, but impacted stones that are way up high, more likely to need antibiotic prophylaxis. The AUA gives specific recommendations for the type of antibiotics, first, second generation cephalosporins, Septra, or penicillin and ampicillin if enterococcus is known to be present. And this is in a single dose pre-op. There was a study in 2018 based out of the Cleveland Clinic that looked at over 1,000 patients with ureteroscopy for stone disease with negative pre-op cultures, the low-risk patient. They found that only 31.6% of patients were managed in accordance to the AUA guidelines, so showing that we weren't so good at following the guidelines. Only 33 patients developed UTIs postoperatively, which was not significant between guideline versus non-guideline based antibiotic therapies. And unplanned hospital visits, I was pretty shocked to see that the upper limit was 27% for patients who had had guideline-based antibiotic therapies, and I thought that was a very high number for bounce backs to the hospital. Low rates for UTIs in both. For PCNL, Dr. Chu and Dirk actually were involved in a multi-center randomized controlled trial of 86 patients comparing 1 week of preoperative macrobid and IV antibiotic prophylaxis in the OR versus no macrobid prescription pre-op. The patients were low risk and had to have a negative pre-op urine culture. They found no difference in the rates of sepsis, admission to ICU, fever, hypotension, or leukocytosis postoperatively, saying that preoperative prophylaxis is not indicated. For cystectomies, there wasn't really any good data out there to support antibiotic prophylaxis or refute it, but most of the guidelines were just based simply on general surgery data. The AUA recommends following the general surgeon's opinion to give antibiotic prophylaxis, and the EAU says single dose is recommended, but may add coverage for less than 72 hours if there's comorbidities or you have a prolonged procedure requiring redosing of antibiotics, and this should cover aerobes and anaerobes. I looked up the general surgeon's guidelines, and they say for any small bowel work that was anticipated, don't need to necessarily treat for anaerobes, but just the cephalosporin single dose pre-op should do. We give Ancef for 48 hours. We hear a lot about urologic hardware and the need for significant prophylaxis. The AUA recommends prophylaxis based on orthopedic data and general surgery data from implants and mesh. They don't recommend based on any urologic specific studies. They say a first, second generation cephalosporin, aminoglycoside should be used, and 24 hours or less after surgery. The EAU says the same kind of thing, recommended, but it's because the devastating effects of having an infected prosthesis requiring explant and making the secondary surgery more difficult. There was no guideline in the CUA. With regards to orthopedic hardware, I found this interesting. This is from the AUA. It wasn't mentioned in either of the other guidelines. They recommend ampicillin and gentamicin or fluoroquinolone prophylaxis prior to a patient who had one of any of the following in each category. So they need to have one from each column. They have to be within the first 2 years of having a prosthetic joint replacement, you get antibiotic prophylaxis. If you have any kind of immunocompromised state, antibiotic prophylaxis, or if you have a joint replacement with any comorbidities listed below on the bottom left there. And you also have to have an increased risk of bacteremia associated with the urologic procedure. So patients with entry into the urinary tract, indwelling Foley catheter, intermittent catheters, indwelling stents, urinary retention, this sort of thing. So you had to have one of each in both columns, which I found interesting. 2 years post-op from a prosthetic joint needing to prophylax for things. I know, but just think about it when you have a patient who says they just had their knee done.
You have to have both of them.
So you have to have one from column A and one from column B. So if you have
All of the guidelines recommend prophylaxis. So if you have, you're getting hurt.
Yeah.
Cracked stones, you're getting trust,
Yeah. But
you're getting cystectomy.
yeah. This one includes shockwave here. Any transmural incision of the urinary tract, whether it's, you'd be getting pretty much antibiotic prophylaxis for all these, but
If you're doing a simple office cysto, like bladder cancer surveillance or something, you're not going to need the right-hand column, so you're going to do it.
You may not, yeah, but if somebody...
Even if it's done last month.
Yeah. So there's a lot of talk about asymptomatic bacteria and what we do with that if we know that information preoperatively. Kai and colleagues in 2017 published in the Journal of Urology the 5-year study of all urologic procedures at a tertiary care center. All patients received antibiotic prophylaxis based on EAU guidelines, and they all had pre-op cultures sent. They looked at 2,200 patients. They found that the only significant risk factor was high comorbidities in their multivariate analysis. So ASA greater than 1, you had a 10 times higher chance of having a symptomatic UTI post-procedure. There was no difference between endoscopic, open, laparoscopic surgeries, and no difference between the type of antimicrobial prophylaxis. So not asymptomatic bacteria doesn't necessarily correlate with disease unless comorbidities are present, basically. So I was run through some of the main guidelines that are present in those three, the North American and the European guidelines. So we're going to talk about some of the risks associated with antibiotics now. So why does antibiotic prophylaxis matter? Why does guidelines matter? Well, we operate in the clean, contaminated world. We're entering the urinary tract on a daily basis, and so our patients, even with adequate antimicrobial prophylaxis, will have somewhere around a 4 to 10% chance of getting a postoperative infection, either in the urinary tract or in the skin. And you can see the kind of risks there on the right-hand column between clean to dirty procedures. It matters because there's a lot of money in antibiotics. We spend a lot, and this was enforced by a 2015 study that was published enforcing the 2011 EAU guidelines for prophylaxis. They took data from 2 years prior to the guidelines and 2 years afterwards. They found no difference in postoperative infections from the non-guideline based and the guideline based treatments. They found reduced number of resistant organisms. They saved 40,000 euros per year in antibiotics and saved 15,000 in postoperative infections. So definitely work to their benefit. From BC data, the Do Bugs Need Drugs initiative, over the course of 2005 to 2014, antibiotic prescriptions fell from 1.79 to 1.53 daily prescriptions per 1,000 BC residents. 342 million annually down to 289 million annually. So this is all prescription, all antibiotics, not necessarily prophylaxis, but something that to think about in that antibiotics are expensive and we use a lot of them, so to be mindful when we're prescribing.
There isn't that thing in the GP's office.
GP.
Antibiotics for cold.
Yeah, this is for all antibiotics, but I just wanted to put some kind of BC data for pricing. I couldn't find find the like actual cost per dose or the number of urologists who prescribe this or that. But I just wanted to have some local data to show just how much we're spending on antibiotics, and initiatives like these to reduce antibiotic use has been proven to save money. Well, why else does it matter? Secondary infections. You hear a lot about C. diff colitis. It is a real thing, and it significantly affects patients. In 2017, at the University of Oklahoma, they looked at C. diff on surgical wards, and it was a retrospective 2-year study. They only had 288 cases, which I found quite low, and only 68 patients had C. diff post-op. And then they took a look at these patients who did have C. diff and what were their risk factors. The only things that came out with any significance were non-recommended antibiotic use post-operatively or in the prophylactic world. You had a 6.7 times more likely chance of having a C. diff colitis event if you had non-recommended antibiotic use. That's at the top there. If you had significant comorbidities, you were 20 times more likely to have a post-op infection. If you had any antibiotics given 6 months prior, you were 20 times more likely if you had antibiotics 6 months prior, 4 times more likely if you had significant comorbidities. And if you were on the orthopedic floor, you were in for a bad time. It could have just been, the years worth of patients that they had. Tough to say, but that's one thing they found significance in. Why else does it matter to have guidelines? Well, we don't really know what we're doing, and that's been shown by multiple studies. And this one in 2018, a survey of 58,000 urologists, 374 responded. This is from Europe, Germany, Austria, and Switzerland. They looked at TERP data and asked urologists, what are you guys using? 42% gave antibiotics more than an hour before surgery, outside of the guidelines. 43% gave inappropriate antibiotics within the time frame that was supposed to be given, outside the guidelines. And 60% extended antibiotic therapy after surgery. And there was no kind of qualitative data around why they chose to, but again, outside the guidelines. So these are some of our favorites: the Cipros, the Gent, the Tobra, Ancef. We even give it to our pets. So what are the bad things that can happen with giving these? And this isn't actually Ancef's logo. This is a florist group that distributes flowers in the Netherlands. So here's just a list of some of the black box warnings on fluoroquinolones. Fluoroquinolones, ciprofloxacin in particular, came out in 1987, and since then there's been a battery of black box warnings slapped on the drug, anywhere from tendon rupture, which we all have heard about, worsening of myasthenia gravis, irreversible peripheral neuropathy. Fluoroquinolone associated disabilities was noted as an actual diagnosis in 2015 to compensate patients for disabilities acquired on ciprofloxacin or fluoroquinolones, and I'll touch on some of those in a second. A lot of these black box warnings came about because of patient advocacy groups and forums and things and lawsuits that were coming out. And in 2016, Carr and colleagues published in the Journal of Community and Supportive Oncology with a very interesting paper that was a combination of basic science and patient reports and this kind of thing. I'd never seen a paper combining basic science and like clinical, qualitative research. So they synthesized some of the patient feedback on these forums, such as Floxed, or My Quinn Story was another forum that patients who had these kind of injuries post fluoroquinolone use posted on. And the list goes on. Statements came out saying you shouldn't be using these for patients with routine non-threatening infections with alternative treatments. They said it should be reserved for serious infections or those with no other alternatives. Particularly bad in the elderly population with attention disturbances, agitation, disorientation, nervousness, memory impairment, delirium, psychosis, And most recently in 2018, risks of AAA rupture or dissection were put on the warnings. So with all these black box warnings, Dr. Ed Cox, the director of the Office of Antimicrobial Products, put out this statement saying, fluoroquinolones have risks and benefits that should be considered very carefully. It's important that both healthcare providers and patients are aware both of the risks and benefits of fluoroquinolones and make an informed decision about their use. I don't know how many patients you give informed information about ciprofloxacin, their side effects and things like that before prescribing, but I think that it's a low percentage, if I were to guess. I think so. I'll get to, basically the short answer is Cipro can cause these side effects with just one dose, and with other antibiotics that are out there, I think there's better, similar efficacy with less side effect profile. So I think reducing the number of doses from 3 to 1 of Cipro would probably be better, and then changing it altogether would be, we could consider it. I'm not sure. I've seen Septra.
Septra data is clearly worse. Well, you can't say that. If you look at the Cipro-resistant bacteria that you get after treating with Cipro, then you're never sensitive to Septra.
Right. Okay.
And that's why I think the answer to Dr. Lange's question is for sure we should stop. It's a warning not to use it.
Yeah.
And a few of our biopsy patients have a problem with using it after us and say, why are you using this?
Why? Yeah. I
It's
agree.
just a lack of really good alternative.
Yeah. And I don't know that there's been a trial kind of comparing Cipro, Septra, Amoxiclav, Ancef, those sorts of things. But would be interesting to take a look at to minimize risk. Wow.
You flip to the antibiogram.
One day, you do it on the same day.
So within an hour pre-op, but what we're doing here is 1 day prior, day of, day after of Cipro.
6 different phosphomycin, 30
Mm-hmm.
So should we be telling our people not to use the recording activities?
So I'll get to that. Yeah.
Drew, is it just Cipro or Levo?
All fluoroquinolones have similar side effect profiles. Yeah. And there's been multiple fluoroquinolones that have been pulled from market because of side effects. So there's only kind of 3 still available in the market. So what does the black box warning actually look like? You hear about this, but what does it look like? This is what's on the actual insert. The big bold font at the top: serious adverse reactions including tendinitis, tendon rupture, peripheral neuropathy, central nervous system effects, and exacerbation of myasthenia gravis. I'll get to this central nervous system effects in a little bit, but they can be quite profound and life-altering or life-ending, as we'll find out. The FDA kind of reports these side effects in a wishy-washy kind of, may do this, may do that, and it's all kind of litigation-focused, but these are definitely real, and they do happen. So they have a black box warning saying that it should only be used if there's no alternative to treatment and only for the following indications: acute exacerbation of chronic bronchitis, down at the bottom here, acute uncomplicated cystitis, or acute sinusitis. So these CNS effects, there's many that are listed here. The fact that they say dizziness, confusion, tremors, hallucinations, depression, and rarely psychotic reactions have progressed to suicidal ideations, thoughts, and self-injurious behavior, such as attempted or completed suicide. That's pretty heavy. And these reactions may occur following the first dose. I read that and I was kind of shocked. Pretty crazy. I'll get to the rates on that in a second. The fluoroquinolones, this study in 2013 looked at all fluoroquinolones and said, what's the risk of tendon injury? 0.08 to 0.2%. So about 1 in 500 patients. that's on a meta-analysis in 15 studies. Seems to be increased with patients using corticosteroids, immunosuppression, transplant patients, advanced age, or within the first month of treatment, you're at the greatest risk. So patients who are physically active, you should be recommending to lay off the physical activity. And that was recommended. Yeah. I mean, the risk is still 0.2%, but it's kind of a risk-benefit ratio.
It's rare not to, unless you see it.
Yeah, exactly.
We're gonna think, we don't problem.
Yeah, we never see it, so there's no problem. Oh yeah. Yeah. This study here looked at the suicidality rates in fluoroquinolones. This was from the FDA's adverse reporting system data. They had 108 patients who met inclusion. There was 120 total, but 108 that met inclusion for their study, and it was, it's a very rare side effect, but something that can happen within 2 weeks of treatment with ciprofloxacin with no past history of psychiatric illness, which is pretty shocking. Ciprofloxacin, 20% of the patients had attempted suicide of those who had this complication, and 80% had completed. And if over 2 weeks of treatment here, still, 33 patients. Tough to say the association if it's directly correlated, but it is data that has to be analyzed and thought about when prescribing. So after all these black box warning came out, what happened? This study tracked 2 years before and 2 years after the label change in 2016, and they showed a decrease in fluoroquinolone prescriptions, but it wasn't statistically significant. So a trend towards better prescribing practices following the guidelines, but so it's still a work in progress. Yeah, I guess just time. Yeah, I found it very interesting that the fluoroquinolone tendon rupture took almost 20 years to come to the forefront for a black box warning. I'm not sure if it was present on like the lower down on the list, but it certainly wasn't the main highlight. No, I didn't see any data like that. No, I'm not sure. I don't think so. And just cognizant of time, I'm going to blow through these. There's some other antibiotics that we use commonly. Gentamicin, tobramycin, just be careful of neurotoxicity and nephrotoxicity. The neurotoxicity is usually auditory vestibular, cranial nerve 8, it's bilateral and irreversible. So always monitor levels if you're going to be prolonging treatment with aminoglycosides, and the pharmacist can help you out dosing these. It's worse in patients with diuretic use or with reduced EGFR, or more prone to it. Cephalosporins, the biggest risk is of pseudomembranous colitis, which we mentioned already. It's seen in pretty much all antibiotics that you'll use, and it's worse when you're using multiple agents or for a prolonged period of time. Overall, it's well tolerated, but always be cognizant of prolonging therapy. Macrobid, significant side effects are chronic subacute or acute pulmonary hypersensitivity reactions. It's not too common, 1 in 5,000 patients or so is what I kind of came across, and the lung function may be impaired permanently. It's usually for patients who are on prophylaxis for over 6 months' time, but can happen sooner. Trimethoprim or Septra, always watch out for the dermatologic manifestations with SJS and toxic epidermal necrolysis. These are pretty bad. Fulminant hepatic necrosis, agranulocytosis, and aplastic anemia are also on their bigger list of warnings.
Now, is that for trimethoprim salt and methoxazole or trimethoprim salt?
Trimethoprim solely, but also with yeah.
SJS is usually salt.
I'm not sure if I pulled that from the Septra warnings or the trimethoprim only. May not, but anyone who you see a rash with trimethoprim or Septra, definitely stop the medication, because it could be their first sign of a hypersensitivity reaction. It could be much, much worse. So quickly, we'll have Dr. Lange come up and talk about some antibiotic prophylactic novel approaches. And this is just a list of some of the things that have been tried in the past, from silver, antimicrobial peptides, chlorhexidine. Antimicrobial peptides, I was doing some reading about, and that seems to be what a lot of people are trying to use these days. They're small peptides discovered in the 1930s. And they're found on bacteria animal cell walls. It's like a natural defense mechanism, and they can be synthetically engineered to adhere to different surfaces, and that's something that we're trying to utilize in urology. So, Dirk. Thank you.
Thank you. So those of you who don't know me, I'm Dirk Lange. I run the Basic Science Research Program at the Stone Center, and one of the areas that we're focusing on is the development of antifouling coatings for indwelling devices, and that's our way of trying to prevent the use of or the need for antibiotics in fighting indwelling device-associated infections. And over the years, as Drew just mentioned, there have been several different technologies that have been tried, and clearly the problem is still quite significant, meaning they haven't worked. And so the question is why, because one of the things is like, you look at new technologies that are coming out, and everybody's just trying to do the same thing. We've got material, we're going to put antibiotics into material. Okay, but that's been tried. You've got to do something different. So what is the problem? Well, the urinary tract. Urine, as you know, is a complex medium, has all kinds of stuff in it. Essentially, the stuff we don't want because it's waste, right? And these components are all highly variable, chemically and physically in terms of their characteristics. And basically what that means, there's something in the mix that will attach to your material of choice. The other issue, too, is that they will start to play with each other and interact with each other, making this an even bigger problem. So this conditioning film, which consists of proteins and other compounds, essentially forms this physical barrier on the surface of your device. And over time, it keeps building up and up and up. And which kind of makes sense is what happens is that basically inactivates whatever novel coating technology you have on there or drug-eluting technology that you have come up with for your material. In addition to that, it may also promote the bacteria attachment. And so we did a study some years ago. This is when I still had hair and I was a fellow. We basically looked at trying to understand the conditioning film components on ureteral stents and trying to understand whether they differ between patients and stent types. And you can see here a list of the most common ones, and it turns out that there's no significant difference in either case, which I suppose is good news, because when you're looking to try and prevent them from forming on your material of choice, at least you have a certain set of characteristics that you can attack, as opposed to having this random mix of characteristics that you're fighting against. And then do they promote, or do they increase bacterial attachment? At the time, we believed they did, but this study clearly showed that when looking at E. coli and Staph aureus, so gram-positive, gram-negative, you can clearly see that there's no significant difference in adhesion and colonization over longer periods of time, whether it's a control stent that wasn't in a patient or one that was in a patient that had a conditioning film. So good news, it doesn't increase bacterial attachment and biofilm formation, but it certainly still promotes it. So one of the things we have to start, this is data from Foley catheters basically showing the same thing, where basically they stain for a fibrinogen and then also bacteria, and basically showed that the bacteria attached to the fibrinogen on the surface of the Foley. So again, showing that this conditioning film promotes bacterial attachment. So what we need to do, and this is what we based our research program on, is taking this conditioning film out of the picture while also obviously fighting the bacteria and trying to prevent them from attaching. And so we've done this in two ways. One is by basically taking the active antimicrobial agent and moving it away from the surface. So even if your conditioning film components start to deposit on the surface, it doesn't matter because your active component is somewhere out here still doing what it does best. The other way is to basically prevent conditioning film components from attaching, basically by repelling them and also repelling bacteria at the same time. So I'll give examples of both of these. We talked about antimicrobial peptides. So this was one of the first strategies we used. Well, basically what we did was we used a copolymer brush, and this is an example of the power of collaboration, interdisciplinary collaboration, because I'm not a chemist, I'm a microbiologist, and so We teamed up with Jay Kitakidatu, who's a polymer chemist at UBC here, and who we collaborate quite closely with. And he does the chemistry, I do the microbiology, and Ben does the clinical part. So it's a fantastic team. So anyway, so what we basically did was we took a copolymer brush that we basically put on the material, and basically what this forms is a hair-like structure on the surface. And to this, through the magic of chemistry, we then attach these antimicrobial peptides, and basically you get hairs that have peptides attached to them that protrude from the actual surface. And so, question is, does this work? And we'll move, I won't bore you with the in vitro type data. We'll move straight to an in vivo type model where we basically tested this in mice, and you can quite clearly see these are fluorescent bacteria. On day 1, all of the mice have a raging infection, whereas on day 7, the ones that had a catheter inserted with the peptide coating on it, most of them cleared the infection, whereas those that didn't have that coating on it did not. And this data here basically shows this in total flux, which is basically measuring the fluorescence coming out of these bladders. This is because I'm an old school microbiologist. All these fluorescent images are all nice and sexy, but I still believe in the old school, actually looking at colonies and counting colonies, because that's the only true way of knowing whether bugs are alive or dead, whether your treatment's effective. And quite clearly you can see here that the number of bugs on the surface is significantly reduced to less than, well, 1 log. And even within the urine, so the free-swimming bacteria, they were also significantly reduced. That was an unexpected finding because the peptides in this case were not being released. So basically what we believed happened there is that just by coming into close proximity with these peptides, the bugs had their membranes disrupted and died, so which was a nice benefit. So again, a nicely effective coating, but the problem with this is, when you talk to industry, they want to know how much does it cost to make. Well, the problem with antimicrobial peptides is that they're still quite expensive to synthesize. So at the moment, while this is still the case, probably not a viable option for an actual coating for indwelling devices, but certainly something that's worth pursuing. So the next approach is, again, physically repelling the conditioning film as well as the bacteria, and there have been various strategies that have been utilized, hydrophilic or zwitterionic polymers, and basically the way that most of these work is by repelling them based on charge or other physical characteristics. The coating technology that we've developed basically is a binary coating, meaning it consists of 2 components. And literally what we do is we take component A, we take component B, we mix it in a beaker, mix it up nicely. We use polydopamine. That is not the inventive process, by the way, so I can openly talk about that. But polydopamine, for those of you who don't know it, if you've ever seen a marine mussel attached to any surface, you can pretty much not remove it, and that's because it actually uses polydopamine as the glue to attach it to the surface. So we used it in this case to basically, use it as the glue. You take the polymer, and when you combine the two and put your material of choice in the mix, it basically cross-links and forms this really thin, 20 nanometer thick, quite hydrophilic layer. And so does it work? Well, the advantage of this too is that we call it a universal highly active coating. Universal meaning that we can attach it to all kinds of materials. You can see the list here. Blue is coated, red is uncoated, silicone, titanium, polypropylene, polyurethane, and the list goes on. We've tried ceramics and so on and so forth. You can coat them all and get this really nice 20 nanometer thick coating. Does it work? Well, you can see quite nicely on all of these different materials when you expose them to higher amounts of Staphylococcus aureus. Uncoated, you can see the early biofilm formation starting here, whereas the coated, you have significantly less. This, by the way, is not bacteria. It's the way that the polyurethane looks under a microscope. In terms of fun and sexy fluorescent pictures, here's some examples again. Staph saprophyticus, E. coli, Pseudomonas aeruginosa. You have an uncoated surface and a coated surface, and again, you can quite clearly see coating the surface significantly reduces the number of bacteria. Is this coating stable? Well, this data shows that it is over a 3-week period. We've stored it in both wet conditions as well as dry conditions at 37 degrees and other temperatures, and I've shown that over that period of time it's highly stable, and the antifouling activity remains. Now, what about the conditioning film? Well, panels A and B here show both BSA and fibrinogen absorption. If you go back to our stent data, BSA and of course from the Foley data as well, fibrinogen are two of the most commonly attached conditioning film components. And from this data, you can see that red is bad, red is fibrinogen, coated is basically black. There's a couple of little spots here, but you can quite clearly see that it repels fibrinogen. And the same can be seen in this data. Decreasing in the curve means attachment of protein to the surface, and you can again see that uncoated has a lot of buildup of the protein, whereas coated does not. To me, panels C and D are the most, pictures worth 1,000 words. This is over 21 and 28 day period. Constant exposure to at least 10 to the 6 bacteria. So every day we replenish the media with 10 to the 6 bacteria. And the difference between the two panels is this is under static conditions, so you just leave it, whereas the bottom is under flow conditions, which of course in terms of urinary tract is much more realistic because we do have flow in the urinary tract. And if you would have heard my recent talk to some of the grad students on uropathogenic E. coli, it actually is one of the characteristics that actually promotes bacterial attachment and infection of that bacterium. So, but you can quite clearly see that over 28 days, we still have a significant reduction of bacterial attachment to the surfaces of these materials. E and F are just, again, it calculates the biomass, so the amount of green essentially, and again, you can see that the red bar, which is basically coated, is pretty much absent in both cases. And G is just scanning electron microscopy images of the same data. Does it work in a living environment? Because it's all nice and wonderful when things work in test tubes, but really we need to test them in more realistic environments. And here's an example of, again, the mouse model where we use ultrasound guidance to put the catheter piece into the bladder. And again, you can quite clearly see exposure to 10 to the 8 CFU per mil of Staph aureus after a 7-day period. Significantly reduced number of bugs on the coated versus the uncoated surface. And just to show you there were actually bugs there, and I'm not just making this up. Oops, these are the numbers in urine. So it works in small animals, but again, all nice and wonderful. We can coat little tiny pieces, but can we coat the real thing? The answer is yes. Here you go. The answer is, you've got a before Foley and after Foley. The nice thing about this coating is that it does give it a bit of a darker color so you can actually see that it's coated. So cosmetically, perhaps not very pleasing, but hey, it works. But anyway, you can quite nicely see that. Now, we've also overcome one of the challenges that other coating technologies haven't, which means that we can actually coat the inside and the outside. It might not show up very well, but this is basically the catheter cut in half just to show you that the inside is coated. And we certainly measured that with all kinds of sophisticated Fourier transformation infrared spectroscopy to show that it's there. And no, I don't understand what any of that does. So, what's that? It certainly does, yeah. It does not, because the way we apply it is with a balloon inflated. So we thought of that one. And again, does it work? Well, here's using this catheter and testing it in vitro, and you can see that you still get 91% reduction. But again, I want you to keep in mind that in these models that we're testing them with, we're basically throwing 10 to the 8, 10 to the 9 bacteria at the system. So these are numbers that they will probably not see in real life, right? And so obviously if they work in that environment, theoretically they should work in the real environment as well. So we moved on to large animals where of course everything became much complicated. So we recently finished this. This is data kind of hot off the press where we actually developed a CODI model in pigs. And so we inoculated these pigs with 10 to the 7 to 10 to the 8 bugs. You might say, well, that's a lot of bugs there, Dirk, but before this, we only knew about mice, and I can tell you, if I take 5 times 10 to the 8 bugs and put them into a bladder of a mouse, they've cleared them by 3 days. So thinking, along the same lines, I thought to myself, well, we'll probably have to put a lot of bugs in there in order for them to kick around, in a pig, which is significantly bigger. Well, it turns out pigs develop UTIs like that. And if I draw your attention to the last bar, which is the average number of bacteria in the pig urine, and you can quite clearly see it's 10 to the 8 per mil of urine. So that's a lot. So again, we have an environment that's almost unrealistic. Okay, and so, I was a little bummed about that at first, going, well, geez, what results are we going to get? But, we look at those results, and you can see, if you compare the coated and uncoated here, for example, pig 4, you can still see, even in this very, very highly infected environment, that there's still a 1 to 2 log decrease in the bacterial numbers on the coated versus uncoated surface. So even in this very complex model, we're still seeing an effect, which is very, very promising. And I do realize I'm biased, but I do think it's quite promising. So that's that coating. So the last approach is we actually also have a coating that's similar, but it actually releases antimicrobial compounds. In this case, we've focused on silver because it's commonly used antimicrobial compound throughout medicine. You've potentially heard of the Bardx catheter, Foley catheter, which is silver impregnated directly into the material. Question is, though, does it work? And the answer is nope. This is a study that looked at 7,100 patients that either had a silver alloy hydrogel coated catheter. They used nitrofuranol coated catheters at the time. The FDA has not approved those, but it was an interesting comparison. And then obviously a control catheter. And essentially what the data shows is that the silver alloy catheter was actually less effective compared to the nitrofuranol catheter, but apparently significantly more comfortable. So I guess that is a bonus there. But the point is that this catheter, which has the silver directly impregnated into material, does not work. But why does it not work? Well, it's because in these systems, the killing relies on the physical interaction between the bug and the material. So the bug has to attach in order to be killed. Well, I have to tell you, dead bugs attach just as well as live bugs. And so what basically happens, much like the conditioning film, is you're going to have a buildup of dead bugs, which then become favorable for live bugs to say, hey, you're covering up and preventing me from being killed. Fantastic. So I'm just going to attach to you. And so over time, you're just basically delaying the process. Okay, but overall, it doesn't change anything. So in terms of our coating, it combines the antifouling technology that I talked to you about before, and through some magic chemistry that I don't understand myself, which is just fine by me, because then at least I can't say the wrong thing and tell you too much. But we actually have effective and sustained release over extended periods of time. And this is our coating here, and this is silver alone. And basically, you can see you can get some nicely sustained release over at least 30 days. We've stopped at 30 days, but we could certainly go longer, which is nice. We've been able to apply this to diverse materials. Again, catheters, PVC catheters, silicone catheters, bandage gauze, titanium wire, polypropylene mesh, you name it. 14-day incubation to at least 10 to the 6 E. coli. You can clearly see this coating works quite nicely on all these material at killing the bugs. How do we compare to Bardx? Well, here's the data. Example 22 is our coating. Again, you look at free-swimming bacteria, and this is the advantage of this particular coating, right? So not only can we prevent bacteria from attaching, but we can potentially treat an already pre-existing infection, which no catheter can at this point, right? So you can clearly see free-swimming bacteria, there was no effect by the Bardx catheter. They increased quite nicely over the 14-day period, whereas in our case, we kept them quite low over that period. Same with the number of bacteria on the surface, and again, this was exposed daily to 10 to the 6 E. coli. Does it work over the long term? Well, again, here's examples from an actual flow model where we can say over a 28-day period. Here's the control, so uncoated. Here's just silver by itself. So the way that this coating works is that the release is triggered by having the polymer in there. So just having silver by itself is not effective at all. But adding the polymer in, clearly you can see over a 28-day period, quite highly effective against E. coli and Staph saprophyticus as gram-positive and gram-negative. And in this case, they were exposed to a stream of greater than 10 to the 8 CFU per mil. So again, significant number of bacteria. Does it work in vivo? This one we've only tested in mice so far. But again, you can quite clearly see Pseudomonas aeruginosa significantly knocked down numbers in the urines, and for MRSA, significantly reduced numbers in both urines and on the surface of the device or the device itself. So To conclude, we've developed 3 novel coatings to overcome inhibitory effects of the conditioning film, at least in mice and pigs, I suppose. We've shown efficacy of all 3 in small animals, shown efficacy of 1 in large animal models, and there's very high potential for at least one of these coatings to decrease the use of antibiotics associated with indwelling devices. So thank you for staying and listening.